All right, guys, welcome back to Underground Science. In this video, we'll be talking about iron deficiency anemia, okay, which is a type of microcytic anemia, okay? So, when talking about anemia, right, we usually classify it into three main types: microcytic, normocytic, and macrocytic, okay? So, microcytic is when the size of your red blood cells are too small. Okay, so what does that mean, right? How do we measure that? Well, if the size of our red blood cells are less than 80 femtoliters, then we classify this as microcytic. Okay, so our size of red blood cells are smaller than usual. If the size of red blood cells are 80 to 100 femtoliters, we classify this as normocytic. Okay, so this is what the size of a red blood cell should be. So it's going to be normocytic. Okay, less than 80 is microcytic, right? Too small. Then if our size of our red blood cells are greater than 100 femtoliters, we classify this as macrocytic. So too big, right? And actually, these are the types of anemia. So we have microcytic anemia, normocytic anemia, and macrocytic anemia. All right. Because we're going to start talking about anemia. We're going to start talking about microcytic anemia, okay, in this anemia series. Let's see what the types of microcytic anemias are. So we have four main types of microcytic anemias that we should be familiar with. So the first type of microcytic anemia, which is what we're going to be talking about in this video, is iron deficiency anemia, okay? That's the first type of microcytic anemia. Another type of microcytic anemia is called sideroblastic anemia, all right? Another type of microcytic anemia is called thalassemia. And the last type of microcytic anemia that we should be familiar with is called anemia of chronic disease, right? So these four types of anemia, these four types of microcytic anemias are the anemias that we should be familiar with, okay? But in this video, we're gonna be talking about iron deficiency anemia. All right, so if we get a quick intro to this, right, it's actually more than intro. I wanted to talk about it here, right, a good amount, and then we'll review our slides that we have to review even more, okay? So now that we got what microcytic, normocytic, and macrocytic even is, right, let's talk more about anemia in general, okay? And there's actually a connection, right? So if we're talking about microcytic anemia, okay, why are your red blood cells small? Because you don't have enough hemoglobin inside of them. That's it. That's the reason for the four types of microcytic anemia we just mentioned. Okay, so why are your red blood cells small? Because you don't have hemoglobin, or you don't have enough hemoglobin inside of them. So you have low hemoglobin inside your red blood cells. Therefore, you have microcytic red blood cells, or red blood cells smaller than 80 femtoliters. Okay. So then, if we looked at low causes of low hemoglobin, right? Or specifically, what I should say is if we looked at what hemoglobin is made of, right? And then we talked about the four causes of microcytic anemia, it would make more sense. So hemoglobin is made up of two things, heme and globin, right? So that's pretty easy to remember. But then we should also know that heme is made up of two things too. All right. Heme is made up of iron and protoporphyrin. All right. So if there's low iron, right, then you're going to have low heme. And if you have low heme, you will have low hemoglobin inside your red blood cells. Therefore, iron deficiency anemia will cause low hemoglobin inside your red blood cells. Low hemoglobin inside your red blood cells will make your red blood cells smaller than usual, hence microcytic red blood cells, so microcytic anemia. So that iron deficiency anemia is a type of microcytic anemia. Okay, so it's just the fact that you have low hemoglobin inside your red blood cells due to low iron. Because remember, heme is made up of iron and protoporphyrin. Okay, so let's look at protoporphyrin then. What if we have low protoporphyrin in our red blood cells, right? If we have low protoporphyrin in our red blood cells, then that means that heme will be low. And if heme is low, hemoglobin concentration is low. And if hemoglobin concentration is low, our red blood cells are smaller than usual. Therefore, they're microcytic. Therefore, low protoporphyrin is a cause of microcytic anemia. What is this called? Sideroblastic anemia. Okay, so that's why sideroblastic anemia is a type of microcytic anemia. All right. So now we understand the two of the four main types. Okay, well let's look at globin. All right, let's look at globin. So if you have low globin, then again, hemoglobin is made up of hemoglobin. So if you have low globin, you have low hemoglobin. If you have low hemoglobin, your red blood cells are smaller than usual, therefore they're microcytic. Therefore, low globin is a cause for microcytic anemia. What is it called if you have low globin chains, right? If you don't have globin chains, adequate amount of globin chains that make up hemoglobin, this is called thalassemia. You remember that's another type of microcytic anemia that we talked about in the beginning, right? So then you're wondering, okay, where does anemia of chronic disease come into this map, right? So it actually comes into play here. So again, if you have low iron, right, then you're going to have low heme. If you have low amounts of heme, you're going to have low amounts of hemoglobin. Then you're going to have a smaller than normal red blood cell or a microcytic red blood cell, which is microcytic anemia. So then why would anemia of chronic disease cause low iron? Okay, and we'll go over that when we talk about anemia of chronic disease in another video. But just know that not only you get low iron due to iron deficiency anemia, okay, but also in anemia of chronic disease, we'll see later, you have low serum iron, okay? And then so that's why you're gonna have low iron, which means you're gonna have low heme, low hemoglobin, microcytic anemia, okay? Right? So that's those are the four main types of microcytic anemia. So now that that makes sense, right? Then we can talk about, well, how do you even get microcytic, or how do you even get iron deficiency anemia? Okay, because that's what we're going to talk about in this video. So let's see what we have here. So of course, this should all be review, right? So anemia in general, right? Microcytic anemia is a hemoglobin production issue. Okay, you don't have enough hemoglobin inside your red blood cells, therefore your red blood cells are less than 80 femtoliters, right? The size of red blood cells are less than 80 femtoliters because you don't have enough hemoglobin production, which means you have microcytic anemia. Okay, so we went over that in our previous slide right now, so that should have been a review. So, and we just went over this, so we'll quickly go over this again, is hemoglobin is made up of heme and globin. Heme is made up of iron and protoporphyrin. If you have low iron, like you see in iron deficiency anemia or anemia of chronic disease, you can get low hemoglobin concentration inside your red blood cells, which means smaller than normal red blood cells or microcytic anemia. If you have low globin chains, right, then you're going to have low hemoglobin again, right, because hemoglobin is made up of heme and globin. Low globin changes thalassemia. Okay, if you have low globin, low hemoglobin, that means you have smaller than normal red blood cells or microcytic anemia. If you can't produce protoporphyrin properly, that's sideroblastic anemia, right? So if you can't produce protoporphyrin properly, you can't produce heme properly. If you can't produce proper amounts of heme, you can't produce proper amounts of hemoglobin. And if you can't produce proper amounts of hemoglobin, your red blood cells are smaller than usual, therefore microcytic anemia. Okay? So let's talk about iron deficiency anemia. So when we talk about iron deficiency anemia, it's in the name, right? How do you get iron deficiency anemia? You get deficient in iron. Because remember, if you're deficient in iron, you can't make heme properly because why? Heme is made up of iron, right? And protoporphyrin. So you can't make heme properly, you can't make hemoglobin properly, your red blood cells are smaller than usual, hence they're microcytic, hence you have microcytic anemia. Okay? So how do you even get iron deficient, right? So iron deficiency, right, can happen due to a lot of reasons. Okay, one of them, of course, is if you're not eating enough iron, right? So if you're not eating enough iron, you can be iron deficient. So this should make sense. Dietary cause should make sense, right? You're not eating enough iron, you're gonna be iron deficient. So for example, right, if we took each one and had examples, what if you have an alcoholic? okay, where most of their calories comes from alcohol, then they're going to be malnourished, right? Because you're not getting any nutrients from alcohol. So this can be one cause, right? Or what if you have an infant who's only drinking, right? Who's only drinking milk and nothing else, right? So they're only drinking, only consuming milk. Well, that doesn't have much iron, right? So of course you're going to be iron deficient there. Okay, so that can be one cause of not intaking enough iron, right? So that's dietary. Well, what if you just lost a lot of blood, right? So of course you're going to lose red blood cells and hemoglobin that way, right? So if there's some sort of traumatic injury and you lost a lot of blood, right, that can be one cause of iron deficiency. Or if another major cause that we should know and be familiar with is GI bleeding, right? Especially in, let's say, a patient who has colon cancer, right? So colon cancer, or they have polyps or diverticuli or ulcers, right? That bleed a lot, then that's another way of losing hemoglobin or red blood cells from our body, right? So that can be a reason we're iron deficient. Okay, because so that's one reason. What about another special reason we should be familiar with is what about hookworm, right? Remember from microbiome that if you have an ankylostoma, right, an ankylostoma infection or a Necator infection, right, who love to go to your intestines and cause slow blood loss, right, slow bleeding. So that's another way of losing iron in our body or losing hemoglobin and red blood cells. So that can cause iron deficiency anemia, right? What about in females who have menorrhagia, right? Heavy periods, that you're losing a lot of blood that way. You're losing a lot of hemoglobin, red blood cells, again, a cause of iron deficiency anemia. Okay, so we have blood loss, dietary, and now we can move on to malabsorption. What if you have a patient who has celiac disease, right? Which affects your duodenum mostly. Okay. So if you have celiac disease, your duodenum, your intestinal cells in your duodenum are heavily inflamed, right? Getting destroyed. Your villi in your intestines that are supposed to help with absorption are atrophied because of the amount of inflammation and destruction that's undergoing there, right? So if your villi are atrophied, you're not going to absorb much nutrients, one of that nutrients being iron. Okay, so that's one way. So any malabsorptive, any disease that has malabsorption, right? Especially celiac disease, because it affects your duodenum where iron is absorbed. Okay, well, what if someone had a gastrectomy, right? Where part of their stomach, right, was taken out. So remember your stomach, right? So if we remember, our stomach produces, specifically our parietal cells, right, produces hydrochloric acid. You need hydrochloric acid in order to absorb iron properly. Why? Because hydrochloric acid in our stomach takes iron in the ferric state and reduces it and converts it into the ferrous state. This, the ferrous state of iron, is what's absorbed, okay? So you need this conversion to properly absorb iron. So if you don't have stomach acid, right, due to maybe destruction of your parietal cells or a gastrectomy, for example, then you're going to have a lot of trouble absorbing iron in its most ready form, right, which is the ferrous state, right? So this is the ferrous state. This is the ferric state. Okay, you want the ferrous state in order to absorb iron well. Okay, and another cause, so that's malabsorption, and so yeah, another cause would be what if you have increased demand for iron, right? So what if you have a female that's pregnant? So that not only does she need iron, but her fetus needs iron, right? Her unborn baby needs iron. So that can be one cause too. Okay, so increased demand. So those are the main causes of why someone would be iron deficient. All right, so now that we know that, we can move on to let's talk about actually iron absorption. Okay, so how does iron get absorbed across the GI tract, right? So first, right, it's important to know that there's different types of iron actually. Okay, so we have one type of iron called heme iron, and then the other type, which you may have guessed, is called non-heme iron. Okay, so what's the difference? Well, heme iron you mostly get from meat. okay? And it's much better absorbed than non-heme iron. So it's best absorbed. This is the form of iron that's best absorbed, all right? And then non-heme iron is from plants, right? So like legumes or leafy greens, and this is poorly absorbed. This is the form of iron that's poorly absorbed, and you really need vitamin C and acid to absorb this form of iron. Okay. So those are two types of iron, right? So let's say you consume iron, all right, and it comes in contact with your gastric acid in your stomach, gets converted from Fe3 plus to Fe2 plus. Then this iron goes to your duodenum, which is the primary site of iron absorption, right? So let's say this is a duodenal intestinal cell, right? This is your lumen, and then this is your bloodstream or your blood vessels, right? So so we get iron, right? That comes in here into your duodenum, right? Your lumen, and then we get iron that actually this iron will move in to this enterocyte, this duodenal cell, right? And it's going to move in through a specific channel, right? So I'm just going to circle that and say that this channel is called a DMT1 channel, okay? DMT1 channel, which is also called a divalent metal transporter type 1 channel. So now we have iron in our enterocyte. Now here we can have iron that binds that can be stored, okay? It doesn't have to exit into the bloodstream, it can be stored in the form of ferritin, all right? So if iron binds apoferritin, it become we get ferritin. So ferritin is the storage form of iron, all right? But whatever, right? That we can talk about that in a bit. So let's focus on the absorption part. So when iron is absorbed into is brought into our enterocyte, then how is iron taken from the enterocyte and into the bloodstream, right? We need another channel here. So this channel is called ferroportin, okay? Ferroportin. Okay, so now we have iron in our bloodstream, but remember, we can't have free-floating iron in our bloodstream or we're going to get really bad free radical reactions, right? Like the Fenton reactions, and which can be damaging to our bodies. So our liver, right, can produce certain proteins like transferrin. Okay, transferrin is a protein, right? So if we draw transferrin, something like this, transferrin is a protein that binds free iron and takes it to places where we need iron. Okay, so then we're going to have iron. So this is our iron. That's going to bind transferrin. Okay, so let's say this is transferrin, right? And then transferrin will take this iron to different places wherever we need it, like where. So well, iron is needed to make red blood cells, right? So we can take this to the bone marrow, right? We can take this iron to the spleen, to the liver, okay? So that we can store the iron also in those places, okay? So one important molecule that we should talk about is called hepcidin, okay? Hepcidin. Now, the reason why we need to talk about this because this is the iron gatekeeper hormone, okay? It's made by who? The liver, right? So liver synthesizes hepcidin. If there's a lot of iron, let's say, or an iron overloaded state, your liver is going to try to produce a lot of hepcidin, right? And the reason why you would produce a lot of hepcidin if you already have a lot of iron is because hepcidin, right, inhibits ferroportin. So if you inhibit ferroportin, you can't absorb iron into the bloodstream from your intestines. So you would want to do that if you already have way too much iron in your blood, right? So, but if you have low iron, then your liver can secrete less hepcidin. Okay. Why? So you don't inhibit ferroportin, so then you can absorb a lot of iron into your bloodstream, okay, and replenish your iron levels. You would want hepcidin secretion from your liver, right? If you have too much iron in your bloodstream, right? Because hepcidin inhibits ferroportin, so that means less iron can be absorbed from your enterocytes to your blood. So you would want hepcidin, right? You would want hepcidin secretion, proper amounts, if you're in an iron overloaded state. But if you don't have enough iron, then you would want no hepcidin secretion from your liver so that ferroportin does not get inhibited, so that iron is readily absorbed from your enterocytes to your bloodstream. Then we said the iron, once it's absorbed, right, can bind transferrin, and then where does transferrin go, right? Transferrin delivers your iron to the places that need iron, right, to the tissue that need iron. So one really important place is your bone marrow, right? Because what's happening in your bone marrow? Erythropoiesis, right? You're making red blood cells, you need iron to do that. So transferrin can deliver this iron to your bone marrow. It can deliver this iron to your liver, right? It can deliver this iron to your spleen and other tissues. Okay, so your liver can store iron in the form of ferritin, right? So ferritin is a storage form of iron. Okay, that's important to know. So so now we've encountered important proteins like like transferrin. We've encountered the fact that ferritin is a storage form of iron, okay? And then we've encountered the terminology of serum iron, right? The amount of iron in your bloodstream. So we should write that down. Serum iron is the amount of iron in your bloodstream, okay? So it's the amount of iron in your bloodstream. That's what serum iron is. Okay, so now we know, okay, serum iron is something we're familiar with, ferritin is something we're familiar with, and transferrin is something we're familiar with. Okay, now the reason why I'm emphasizing these things is because it's gonna be really important when talking about the labs of iron deficiency anemia. Okay, so ferritin, right, is a storage form of iron. If ferritin is low, okay, so that means we don't have much iron stored, right, in our cells. If ferritin is low, then wouldn't you want transferrin to be high, right? You would want transferrin levels to be high in the hopes of bringing iron to your tissues, right? Because that's what transferrin does. If your tissues don't have much stored iron in that form of ferritin, then you want transferrin to bind more iron and bring it to your tissue so that you can have more stored iron in the form of ferritin. So, so how do you measure transferrin when you're doing labs? So you can indirectly measure transferrin amounts by measuring your TIBC, your total iron binding capacity. Okay, so TIBC we know is basically indirectly talking about transferrin, right? So that will refer to TIBC as transferrin now, so it's easier to understand. Then we're familiar with ferritin, we're familiar with serum iron, right? What that means. But then we should also be familiar with something called transferrin saturation. Okay, transferrin saturation, right? So the percent saturation of our transferrin molecules, right? So it's going to be a percent value. Now, why is this important? Because we use this, right, when we're talking about labs, when we're talking about anemia. So what this is saying is percent saturation of transferrin, right? Well, this is measuring how much, right? How much iron is bound to transferrin. Okay, that's what this is measuring. That's what percent saturation of transferrin is measuring. Now, in iron deficiency anemia, your serum iron is low, right? So then obviously you would expect not much iron bound to transferrin because you don't have iron to bind to transferrin, right? You don't have much iron in your blood in the first place. Okay, so you would expect your percent saturation of transferrin to be low too in iron deficiency anemia. Okay, but these four things, right? Percent saturation of transferrin, serum iron, ferritin, and TIBC, which is indirectly measuring transferrin, are really important when it's going to come to talking about the labs. Okay, so now that we know absorption and these four lab values, right? Let's move on and see what we have next. So when you're deficient in iron, right, you need iron to make proper red blood cells, and we know red blood cells, right, deliver oxygen to your tissues. So if you're deficient in iron, you're not properly making enough hemoglobin, right, which is present inside your red blood cells, which means you can't properly deliver oxygen to your tissues. So you can expect fatigue, right? or shortness of breath on exertion because you don't have enough oxygen to upkeep exercise, right? Pallor, okay, headache, right? Weakness. So all these symptoms, make sense in iron deficiency anemia. But three main things that we should be familiar with is pica, right? What's pica? It's the desire to consume, right? Things that aren't food. So basically like dirt or clay, right? So that's what pica is. All right. So it's basically the desire or craving to have non-food to basically not ingest food. Okay. Instead, they have the craving to ingest things like ice or dirt or clay, right? Things like that. So that's what pica is, and that's specific for iron deficiency anemia. You can also see koilonychia, right? What's this? Koilonychia is another word for spoon-shaped nails. Okay, so we should keep this in mind too. So pica, koilonychia, you can see glossitis, which is a smooth inflamed tongue, right? Smooth inflamed tongue. All right. So this is you can think about this when thinking about Palmer-Vincent syndrome, which is uh, you find a triad of symptoms, right? So when you're thinking about glossitis and iron deficiency anemia, you should think about Plummer-Vincent syndrome. Plummer-Vincent syndrome is a triad of dysphagia, esophageal webs, and iron deficiency anemia. Okay, and then also another finding would be glossitis. Okay, so keep that in mind too. If the patient has trouble swallowing, if they're also iron deficient, right, and they have low hemoglobin, a MCV of less than 80, and they have a smooth and inflamed tongue, think about Plummer-Vincent syndrome, okay? But also keep fatigue, pallor, weakness, headache, dyspnea on exertion, pica and cholionicia in mind too when talking about iron deficiency anemia. Another thing you can see in iron deficiency anemia is called angular chylitis, okay? So another thing you can see is something called angular chylitis. Oop, can't even write. Chylitis, all right? So what is angular chylitis? It's when you have cracks, right, in the corners of your mouth, okay? So when you have the cracks in the corner of your mouth, in the corners of your mouth, okay? This can also happen if you have iron deficiency anemia. Another feature to keep in mind is restless legs, right? You can also see this in iron deficiency anemia. And we already talked about Plummer-Vincent syndrome, right? Which is the triad of dysphagia, iron deficiency anemia, esophageal webs, but also keep in mind that in patients who have Plummer-Vincent syndrome, they also have glossitis or smooth inflamed tongue, okay? And remember esophageal webs, right, which is the outpouching of mucosa, right, of your esophagus, that can trap food, okay? And if that happens, you can irritate your cells that make up your esophagus. So that's why esophageal webs, right, increase your risk of squamous cell carcinoma, okay, of your esophagus. So that's important to keep in mind too. But we'll talk about that when we do our GI playlist, okay? So those are the main clinical features to know about iron deficiency anemia. Now, before we move on, right, I want to talk about the stages of iron deficiency anemia, okay? Before we move on to the labs and treatment, because there's stages of iron deficiency anemia, okay? So there's four main stages we should be familiar with. Okay, so we'll write that out. So we have stage 1, stage 2, stage 3, and stage 4. Okay, there's four main stages. All right, so in stage 1, right, when you're deficient in iron, right, remember what's the storage form of iron? Ferritin, right? Ferritin is a storage form of iron and it's readily accessible. Okay, so you can extract the iron that's stored as ferritin inside your tissue, right? And help in restoring your serum iron levels. So first, what's going to happen is you'll deplete your stored iron, okay? You'll deplete your stored iron first. So you may see a low ferritin level when you do labs. However, remember well, we didn't say deplete serum iron yet, okay? We're depleting stored iron first. That's important to remember. That's stage one of iron deficiency, okay? Stage one is you're depleting your stored iron first. Then, once you've depleted your stored iron, so you have low ferritin levels, right? Then you start depleting your serum iron, okay? The iron inside your bloodstream, okay? Then you just start depleting. So let's say it depletes. Then you start depleting your serum iron, okay? So if you start depleting your serum iron, right? Next, then what happens? So for let's go one step back again. Okay, so if you're depleting your stored iron, right? What does transferrin do? It takes iron to your tissues. Okay, well your tissues are depleted now of stored iron. Therefore, that's why you have low ferritin. So what would you expect transferrin levels to be at? You would expect transferrin levels to be elevated, right? So you expect a high TIBC, which is indirectly measuring transferrin, remember, right? So you'd expect a high TIBC because you want transferrin to be binding to iron and bringing it to your your tissue, right, your cells, so that you can have more stored iron. So if ferritin is low, you can expect TIBC to be high. Okay, and of course we said you deplete your serum iron next, stage two. So your serum iron now will be low. Okay, so that's stage two. Now stage three is when you get low hemoglobin, right? So you try to absolutely use all your iron before your hemoglobin production drops. Okay, because now you don't have stored iron or you don't have serum iron. Okay, so you don't have iron anywhere in order to properly synthesize heme and properly synthesize hemoglobin. So then the only option is to drop production of hemoglobin. So your hemoglobin concentration inside your red blood cells will now drop. Okay, so now you're going to be microcytic, right? And then, so once you're microcytic, now stage four is what you would expect is your red blood cells to be small, right? Because they don't have enough hemoglobin anymore, and pale, okay, also called hypochromic. So in iron deficiency anemia, what do we get? What's the end result? Microcytic and hypochromic, right? Because you don't have hemoglobin anymore inside your red blood cells as much, right? So then you get a pale appearance, which is what hypochromic means, red blood cells. Okay, so that's the end result of iron deficiency. All right, so those are the main stages that I wanted to discuss before we moved on to labs. Okay, so now let's talk about labs. So of course, if you're deficient in iron, your serum iron, remember, it gets depleted in stage two of iron deficiency. So you'd expect a low serum iron, right? Because you're deficient in iron. Remember what happened in the beginning of iron deficiency? You depleted your storage form. So it makes sense to also expect low ferritin. Now, we said if you don't have much iron stored in your tissues, you would expect transferrin levels to increase in the hopes of bringing iron to your tissues. So that's why it makes sense to see elevated TIBC, right? Elevated transferrin levels. Okay. And then if you don't have enough iron in your serum, right, then you don't have enough iron to bind to transferrin. Therefore, your transferrin saturation percentage is also going to be low. Okay. So you see low serum iron, low ferritin, low transferrin saturation, but elevated TIBC, okay, which is indirectly measuring transferrin. Okay, so that should make sense when you're trying to do labs for iron deficiency, right? And of course, if you don't have enough iron, right, which is stage three, remember, you don't have enough storage iron, not enough serum iron, so then you stop making adequate levels of hemoglobin. Okay, so then that means your hemoglobin levels will be low, right? If hemoglobin levels are low, your red blood cells will be smaller than usual. So your MCV will be low, right? How low? Less than 80 femtoliters. Okay, so microcytic. And then if we also talk about uh, your um, your your mean corpuscular hemoglobin, right? So how much hemoglobin is inside your red blood cell, or your mean corpuscular hemoglobin concentration, which is the concentration of hemoglobin, right, in a certain amount of red blood cells. Well, you don't have iron, right? You don't have enough iron, so you can't make enough heme and you can't make enough hemoglobin. So then your mean corpuscular hemoglobin or your mean corpuscular hemoglobin concentration, right, will be low. Okay, so that's expected. right? So that's important to keep in mind. That's why you have hypochromic, right? Red blood cells. So, so hopefully these lab values make sense. And of course, you can also expect your red cell distribution width to be elevated, okay, indicating that your red blood cells vary in size, okay? Your red blood cells vary in size, okay? Some red blood cells may be bigger, some may be smaller, some may be normal, and etc., right? So that's it, right? So if you have low iron, a high TIBC, low ferritin, low transferrin saturation, that's will clue you into iron deficiency anemia. Other things that can help, remember, are, if you see pica or koilonychia or glossitis, when if you see glossitis, esophageal webs, dysphagia, and iron deficiency anemia, you should think about Plummer-Vinson syndrome, right? If you see low hemoglobin or hematocrit, low MCV, right? That's to clue you into iron deficiency anemia also, or a microcytic at least. All right. And then, of course, if you symptoms like weakness, dyspnea on exertion, pallor, fatigue, right? Headache, dizziness, things like that, that should help you diagnose iron deficiency anemia. So if you did a peripheral blood smear, as we talked about, you would see microcytic. Why? Because you have low hemoglobin. Hypochromic. Why? Because you have low hemoglobin, red blood cells. Okay. So now that we're familiar with all that, we can talk about the treatment. Okay. So let's talk about the treatment. So what would we see in treatment? Well, remember, what did we say what the cause was for iron deficiency anemia, right? One thing we mentioned was GI bleeding. What if you have a patient, right, an elderly patient who has ulcers, for example, or polyps or diverticuli or colon cancer, right? And they're bleeding a lot from their GI tract. Then that would mean you're losing red blood cells, right? You're losing overall hemoglobin. Okay, or what if they had a parasite infection like ankylostom or Necator, right? That's slowly bleeding, that's causes slow bleeding, right? Slow GI bleeding, which again contributes to deficiency of iron. So you try to treat that first, right? Or if someone had celiac disease, right? Or someone had parasites, or someone you found out through history taking, right, that the patient wasn't getting enough nutrients, or for example was an alcoholic, or for example was an infant who was only getting milk, right, and nothing else. Then you would try to change that first, right? So you want to treat the cause first of iron deficiency anemia, then focus on giving iron because that's what they're deficient in, right? So that's what we have here. So after treating the underlying cause, then you would give iron in the form of ferrous sulfate, right? And it would be a good idea to also add vitamin C because that helps with the absorption of iron, right? So not vitamic, but vitamin C. All right. And then, of course, what if they have celiac disease or severe anemia or severe malabsorption, something like that, where oral iron won't really help, right? Because if you have some sort of malabsorptive disease like celiacs, even if you give iron, you can't properly absorb that across your duodenum because you have atrophy of your villi and a lot of inflammation and destruction of your duodenum, right? So in that case, you'd want to consider IV iron, right? So IV iron in those in that patient population. Okay. And then after that, you just monitor, right? And wait for the hemoglobin to normalize. Another thing I wanted to quickly talk about and mention, since we didn't mention it in the labs, right? It is the Mensur index. Okay. So the Mensur index. All right. This can be a little useful, right? Because what is the Mensur index? What is the Mensur index, right? It's your mean corpuscular volume, okay, so your MCV, which is in femtoliters, as we're familiar with, divided by your red blood cell count. So your number of red blood cells. In iron deficiency anemia, we already know you have a low MCV, but more than that, you have an even low number of red blood cells. So you can expect your Mensur index to be greater than 13. Okay, that's the number that we're targeting. So if you're greater than 13, right, then that can indicate a low red blood cell count. Okay. So that's important to know too. Okay, you would see a Mensur index greater than 13 in iron deficiency anemia. All right. Okay. So hopefully, right, this video helped because that's all for iron deficiency anemia. Hopefully it wasn't too confusing or anything. Hopefully, it helped a little bit. Thank you guys for watching and see you guys in my future videos.